It is my singular honor and our privilege to welcome you all to this very important webinar. I'll be moderating today's webinar. Dr. Balalo Mborate is my name, a senior medical officer and a member of the case management pillar, National Lassa Fever Technical Working Group from NCDC. I would like to welcome you all yet to another Lassa Fever outbreak webinar series. This is the third of its kind. Recently, NCDC, together with its supporting partner, has been holding Lassa Fever outbreak series, webinar series. But this very particular third series is intended to improve awareness and discussion on practical steps to ensure readiness for the 2025 Lassa fever outbreak season. You will agree with me that this very series of webinars are timely as we are just about to enter the 2025 Lassa fever outbreak season, where the peak of transmission is usually around December to April. So today's webinar is centered on case management with the title High Index of Suspicion for Lassa Fever and Treatment Center Readiness. Perhaps it is absolutely timely to have discussions and conversations focusing on the importance of maintaining high index of suspicion for Lassa fever, especially in clinical settings where, clinicians, patients present with common febrile illnesses like malaria, typhoid, and co. So it is absolutely critical for clinicians to, be on alert because early detection of suspected cases with prompt diagnosis and effective management of those confirmed cases are, critical in reducing the morbidity and mortality of Lassa fever. So it is important in ensuring the readiness. It is important to actually ensure readiness in the designated treatment centers, in making sure there are available resources. IPC measures should also be in place, and then the trained personnel, very important, because they are the ones that will manage the suspected cases. So today we have a quite number of experts who speak to us and will share their valuable insights, in early warning signs, and then implementing best practices in clinical management and strengthening capacity, around those clinic treatment centers. So once again, on behalf of the National Lassa Fever Technical Working Group, I thank you all for joining this webinar. We are quite excited to have your insights and experience as we forge ahead. So at this very moment, I would like to invite the incident manager, the lead of the National Lassa Fever Technical Working Group from NCDC, in person of Dr. Yetunde, to take us through the webinar objectives and expectation. So Dr. Yetunde, you have the floor.
Okay, thanks, Dr. Bala, for that warm welcome. Colleagues, good morning, wherever, or good day, wherever you're joining us from around the world. Please, can I have my slides up? Great. So looking at the series that we have for today, we have the following objectives: to encourage high index of suspicion for Lassa fever among clinicians. We also want to be sharing from the wealth of experience that we have when it comes to Lassa fever readiness in Nigeria. We also want to make sure through this, we also improve early reporting of Lassa fever cases from communities. And our expected outcomes at the end of this webinar is to ensure that we have improved readiness for Lassa fever management and control across the length and breadth of Nigeria, within and around our borders, of course. Next slide, please. So in our usual manner, the ground rules for this presentation, the NCDC remains committed to providing an enabling environment for all our webinars. And this ensures that any of our events is inclusive, respectful, and a safe environment for all. So our rules for these webinars are all participants are expected to behave with integrity and respect. Kindly self-introduce yourself in the chat box only, and only questions in the Q&A box. You will see the Q&A box with a question mark. That's the only box. Questions in those boxes are the only ones that will be attended to, please. And kindly respect everyone's opinion. All right? Thank you so much, and we look forward to a healthy and safer Nigeria through prevention and control of disease of public health importance. All right, over to you, Dr. Bala. Thank you very much. Yes, so over to you then.
All right, thank you very much, I am. So going by the agenda, we are to have the pre-test. So can we start? Can you move to the first question?
All right, thank you very much.
So once we have 50% response, we are moving to the next questions. Is it up to 50%? Let's move to the next question. Once the response is up to 50%, we move to the next question. Thank you. Yes. This is the last question. Yeah, so are we done? All right, thank you. Thank you very much. So, distinguished participants, as we plan to, hello? Yeah, so going by the agenda, let me take some moment to introduce our expert speakers who will be taking us through various presentations today. So on the list, the first speaker is Dr. Joseph Okogwele, a director at the Institute of Viral and Emerging Pathogens Control and Research from Irua Specialist Teaching Hospital, Edo State. He's a senior lecturer at the Faculty of Clinical Science, Ambrose Ali University, Edo State. He is a seasoned clinician, a researcher in infectious diseases, dedicated to serving vulnerable population, particularly pregnant women, children, elderly, and IDPs. His expertise spans managing high-priority pathogens, and leading mobile laboratory deployment during the outbreaks. He has been responsible for coordinating human resources across regions in Nigeria, responding to Lassa fever and other high-priority pathogens during outbreaks, leading clinical operation work streams in trial development of new vaccines and therapeutics for Lassa fever, performing life-saving surgeries during outbreaks, and providing technical support to WHO clinical network and guideline development groups. He has published and presented over 50 papers on emerging infectious diseases in high-impact journals and conferences. He will be talking to us on high index of suspicion for Lassa fever, what healthcare workers need to know for all age groups and population. Then still on the list of speakers, the second speaker will be Dr. Winifred Okponu. She is an associate director at the Georgetown University Center for Global Health Practice and Impact, with nearly 20 years of experience in clinical medicine and public health. She specializes in global health security, outbreak management, and IPC, and case management of emerging infectious diseases. She has provided technical support, technical assistance to NCDC for decades, focusing on surveillance, case management, emergency management, IPC for viral hemorrhagic fevers. She has played a role in pioneering capacity building initiatives such as Nigeria's first public health emergency management intermediate course, and the development and implementation of clinical management fellowship for Lassa fever in collaboration with Irua Specialist Teaching Hospital and other institutions. Dr. Winifred is also leveraging on innovative approaches to combat Lassa fever through a local innovation scale through enterprise network framework. Her expertise extends beyond Nigeria. She has contributed to strengthening pandemic preparedness and public health system across Africa, including work on Global Fund COVID-19 response mechanism and supporting national public health institutions in several African countries. A pioneer in capacity building, she has played a key role in designing and implementing the 34-week Public Health Emergency Preparedness Response and Recovery Fellowship Program, and now in its first cohort in West Africa. She has participated in advanced training program worldwide, earning certificate, and has authored several peer-reviewed publications in her areas of expertise. She is an advocate of membership and leadership. She aspires to share her knowledge globally through teaching and continues to publish researches in her areas of expertise. So ladies and gentlemen, Dr. Winifred will be taking us through improving treatment center readiness and utilizing it as a useful tool in response architecture. So the third speaker, with Dr. Tunde John Aremu, an infectious disease and public expert at the Federal Teaching Hospital, Gombe, with over a decade of experience in case management of viral hemorrhagic diseases, including Lassa fever. He is the lead coordinator for case management in the isolation center in Gombe State and currently leads the case management pillar at Gombe State PHEOC. He also held the position of DBTIM for Lassa fever EOC. On many occasions, has been instrumental together with his team in achieving low case fatality rates for Lassa fever in Gombe State. Currently, he is the state national clinical mentor and has been in the forefront of driving the government sustainability agenda, building the capacity of healthcare workers in case management, IPC of epidemic-prone diseases, and strengthening resilient health system. He is a pioneer fellow of the Lassa Fever Case Management Fellowship Program. He has received various certificates in leadership and management, policy, advocacy, system building, project management, and strategic leadership management from prestigious Lagos Business School. He is an advocate for continuous quality improvement. He is also a member of the Nigerian Infectious Disease Society and a member of the Nigerian Medical Association. So he will be, taking us through a presentation on the case study, cascade of clinical care and linkage to the EOC as coordinating mechanism for outbreak response. So at this junction, ladies and gentlemen, I present to you the first presenter on the list, who is Dr. Joseph Okogole. He will be taking us through the high index of suspicion for Lassa fever, what healthcare workers need to know for all age groups and population. Dr. Joseph, you have the floor.
Thank you. Good morning, Dr. Bala. Good morning, my co-panelists. Good morning, everyone on the call. First, let me appreciate the Nigeria Center for Disease Control, the Director General, and the organizers of this program for coming up with this initiative. This is quite apt at this time, particularly now that we are moving into another period of an outbreak of Lassa virus disease. I think this is such a good time to probably remind us of some of the things we need to know, so that we'll be able to attend to the possible outbreak that is going to come. Good morning. I will start with, I'll go with the following outline as slightly projected on the slide. Lassa fever is one of the viral hemorrhagic fever, and since 2018 have been classified by the World Health Organization as a priority disease for research and development. We are also aware that over the past 55 years in Nigeria and many other West Africa sub-region, we have had repeated and recurrent cases of Lassa virus disease. And currently it's estimated that over 37.7 million people in 14 West Africa countries are at risk of being infected every year, with over 5,000 to about 60,000 deaths yearly. This has actually been extrapolated. And it's good to know that Lassa virus disease affects all age groups, males, females, children, and as a matter of fact, affect pregnant women as well as their fetuses. So it's therefore important that the issues of Lassa fever should always be put at the burning table, particularly at this time that we gradually approach an outbreak season. We already, as clinicians, have some knowledge about the modalities of transmission. And it's important to mention that in over 90% of cases, as has been demonstrated by many metagenomic studies and some sequencing studies, the disease is mainly transmitted from rodents to humans. Human-to-human transmission have been found to be very low, very low. The major route of transmission should remain from the rodent to the human. And there are many ways this could happen, either by ingestion of food that has been contaminated with excrement from these rodents, or handling, during the process of handling these rodents and consuming them as some of our delicacies. Some of other routes will include the human-to-human transmission, particularly when in hospital environment, it could be nosocomial, or we stay with people who have had this disease, but probably, we're not properly diagnosed, or who died from a febrile illness, who were not diagnosed to have Lassa fever, or people who had direct contact with those who have been confirmed to have Lassa virus disease. So it's important for us to put this in our mind so that we can be very cautious of some of the preventive modalities we need to take, particularly at this time. Now, one of the reasons for this presentation is to discuss the need for every clinician, doctors, nurses, to have a very high index of suspicion for febrile cases, particularly. I mentioned febrile cases because over 90% of cases of patients with Lassa virus disease will come in with fever. And for the fact that there are many other conditions that could present with fever, it's important for us to raise our suspicion a bit so that we can easily suspect patient and be able to triage quickly and immediately, and then diagnose promptly. And over the years, we have been able to find some fatality-related risk factors from our review of many cases that we have actually seen over the years. And we saw that one of the commonest causes of death in many cases include delay in making diagnosis, low index of suspicion in the part of clinicians, doctors, and nurses, which will lead to delay in collection of sample, delay in diagnosis, and of course, late referral from private and public hospital, delayed presentation to referral centers where diagnosis can be made, as well as early institution of supportive therapy to manage some of the complications these patients may have developed. So the index of suspicion is very key. And to have a high index of suspicion, we need to have some knowledge about the common clinical presentation of patients who have had Lassa virus disease. And some of these presentations, like I already mentioned earlier, will include fever. Fever is almost always common. And for the fact that many patients will come to you and probably tell you that they have had some anti-malaria, they've been treating malaria, they've taken some anti-malaria, and they've gone to their chemist, pharmacies, and all that to buy antibiotics. But even when the fever is coming down with the paracetamol, they still remain very ill. They have malaise, they have weakness. Some of them begin to develop jaundice. And subsequently, in some early complications, some could come down with reduction in urine production when the kidneys are already being affected. If you are lucky to find some patients who will come in with sore throat, which are very typical, those with retrosternal chest pain, abdominal pain. In some cases, you could have some patients, particularly among adolescents, presenting in some institution with abdominal pain, very atypical. And oftentimes, many surgeons may make diagnosis of appendicitis. Some will make diagnosis of typhoid enteritis, and they may have had a surgery on some of these patients. Negative laparotomy, we have it most of the time. I remember Dr. Dongo reported a couple of cases in our facility, and is a very common occurrence that we have, from surgical acute abdomen, and eventually the person turns out being positive to Lassa virus disease. There may be other organ affectation which could be very apparent, like renal affectation. Patients should come in with seizures. Then in severe cases, they come in with shock, and then another constitutional symptom. Bleeding diastasis are common in late cases when patients begin to bleed from orifices. It's actually indicates that it's becoming very severe, and the chances of fatality could be high at that point in time. So this is very key for us to know. Now, having known all this, these are common clinical findings with clinical symptoms and signs we may find in adults. But when you come down to children, They may not typically present, they may have most of these features which I have mentioned, malaise, weakness, vomiting, bleeding from orifices, acute kidney injury and all that. But children can also present with very atypical symptoms. And that is why when we are dealing with children that we suspect probably are having atypical, presenting with atypical complaint, it's important to always call in the specialist, even the pediatrician, who is not so vast with this atypical presentation in Lassa fever children, who could make a call to some colleagues and have some good guidance on what to possibly expect in children like this. For children with Lassa fever, they can easily come up with acute fever, very severe fever, and sometimes when they have acute fever like this, they become dehydrated, they come in with shock, they come in with all sorts of things. We must also understand the fact that children are not small adults. They shouldn't be managed, like Professor Beden will always say, children are not small adults and should be attended to as if they are small adults to reduce the dose. They are not small adults. They should be attended to based on a very scientific way, based on their pathophysiology, unique pathophysiology in children. Children can easily present with features of gastroenteritis. Gastrointestinal symptoms are very common in children with Lassa viral disease. And then the sepsis outlook may also mimic pneumonia in children. So pneumonia can be very common in patients that have been diagnosed with Lassa viral disease. Again, there are some signs that are also common in children. Jaundice, hepatomegaly are common and very prominent in children with Lassa viral disease. These and some other features which I have mentioned are also common, and we must watch out for many things like this. This will also include, in some cases, generalized body swelling in some children, which have also been reported in many cases. Pregnant women particularly are a unique population, because when you're dealing with pregnant women, you're actually dealing with two people at the same time. You are dealing with the pregnant mother, you are dealing with the pregnant child, and they can present in a very unique way, which made them very vulnerable. And the chances of death of a pregnant patient is higher when you compare to adults and children. When general case fatality rate has been reported to about 15 to 21% for many adults, the fatality rate for pregnant men has been reported to be at about 35 to 65% in many cases. And of course, fatality for the fetuses could be as high as 100% for many cases and in some centers. So you must pay attention to these unique features in pregnant women. Apart from the symptoms I've mentioned for adults presenting with fever, malaise, weakness, generalized body weakness, and a couple of other things like sore throat, retrocranial chest pain, pregnant women with febrile symptoms and early or late pregnancy losses should be a high suspect for Lassa virus disease. Unexplained pregnancy losses, which will come as a form of miscarriage in first trimester, missed abortion, unexplained fetal death in second and third trimester, women. And sometimes when we take a peep, we take a look at some of these cases, when you take a look at some of these cases, and of course, we are able to, when we take a look at some of these cases and we are able to tie them up with their clinical signs and symptoms, we're able to also figure out something out from this pregnant patient. For example, there are unique clinical presentations such as breast swelling, which you will find when you perform a breast examination for some of these patients. We call it the breast sign. The breast sign in which this is the breast sign. A pregnant woman with Lassa fever will present with a swollen breast. The breast is engorged. There's usually no breast mass. She is febrile. The breast is tender. There's no breast mass. There's no breast milk discharge. The breasts are just swollen. Oftentimes, this is a good prognostic feature because most of the patients we have found with this breast sign often end up as survivors. And when they come in, their fetus is usually alive and well. So as the woman gets better, as the patient gets better, the breast signs usually resolve, and then they tend to return back to their normal state. This is very key. And of course, a pregnant woman coming in with an intrauterine fetal death should also be taken very seriously, because the chances of that patient dying is very, very high. So IUFD in a pregnant patient is a poor prognostic feature and should be taken very lightly for immediate evacuation. Now, when you have all these clinical symptoms and signs, it's important for you, even when you don't have facilities to quickly perform a PCR diagnostic, there are some investigations you can do that may give you a lead. Lead means it's going to tell you that possibly what this person has could be Lassa virus disease. Example of this is common urinalysis. You do your urinalysis and you're having proteinuria, you're having microscopic hematuria. Just on dipstick urinalysis, you may be able to make an impression that this could actually be a Lassa virus patient. And then when you have an elevated liver enzyme or low platelet count, it could also be suggestive. Anemia may not be so common at the time of presentation, but subsequently, by the time you are commencing ribavirin, all Lassa positive patients eventually, with severe cases, will eventually need to get blood transfused. But you have anemia, either coming from the use of ribavirin or from the disease, with the progression of the disease itself. If the kidneys become affected, the erythropoietin production, which is blood production, will also be low. And of course, the drug you are using, there could also be a slight marrow suppression and a couple of other things that may happen, leading to anemia, which is very common. It's something we could expect. And of course, if the person starts bleeding, anemia becomes a very common clinical presentation which you could have. So the ancillary investigations are very key. You don't need to do a PCR first before you properly triage a suspected Lassa virus positive patient. Yes, after this has been done, you now have a very high index that possibly this patient could have Lassa virus disease. What do? Every center is always important for us to have a holding area, what we call a holding area. It can just be a dedicated space, a dedicated room at a time, which is dedicated to suspect cases for any form of viral hemorrhagic fever. It could be Lassa fever, it could be yellow fever, it could be Marburg, it could be dengue fever. You must have that. You have all the items here, the PP and a couple of other things, so that the patient who is suspected to have Lassa fever can be quickly isolated from other patients at the entry point of the hospital. There are many entry points in the hospital. I have the accident and emergency unit, the children emergency unit, the labor ward. These are all entry points in the hospital. The gynae emergency unit. You must have this dedicated room. As we continue to have increase in number of cases of emerging with different types of disease being emerging that are high priority and very infectious with potential to cause fatality in humans. So there are public health diseases that need to be properly triaged. So once these patients are triaged into this room, they should be commenced on supportive therapy. Supportive therapy is key. In fact, the hallmark of managing a patient with viral hemorrhagic fever is to support. Dehydration, shock will kill the patient faster than the disease they have. Complications will eventually lead to development of renal complication, liver complication, a couple of other things. But with supportive care, you give this patient a chance to live longer, an opportunity for you to get a definitive diagnosis and institute definitive care. This is very key. Correct appropriately. Non-pregnant adults give the relevant field, call in the physician, get their input, call in the specialist based on their presentation. If it's having bleeding complication, call in the hematologist to manage for you. It's multidisciplinary care. You can't start the management alone and end alone by yourself. You must call in the relevant subspecialty or make call. You can make some calls and people will assist you in guiding you through on how to carry out some of these modalities of care. This is very key, and we have to take this very seriously. So I want to I want to pause a bit at this. I want to pause a bit at this point, and then I will conclude because of time. By laying emphasis on the fact that yes, Lassa fever is a significant public health concern in Nigeria and of course the whole of West Africa sub-region. It's important that we implement the best practices, particularly during the period of surge. In applying the One Health approach remains desirable. All subspecialties must come together, prepare, strategize, and act. There must be a high index of suspicion. This cannot be overemphasized at this period. All efforts should be made to also support researches that promote the development of innovative countermeasures, particularly vaccine, because the only veritable strategy to still end the scourge of Lassa viral disease, which have continued to plague us over the past 55 years, is by developing vaccine. We can't completely take away the rats in our bushes. We must be able to develop vaccine that will now eventually eradicate this form of disease. Thank you very much. Over. Thank you.
Thank you very much, Dr. Joseph, for this wonderful presentation. So at this, distinguished participants, we can please make use of the chat box to drop any questions, concerns regarding this very presentation. Myself and my supporting, okay?
The Q&A box, please, not the chat box, because the chat box has a lot of introductions. So we want to make sure that all questions.
The Q&A box, sorry.
Thank you.
Thank you. Let's make use of the Q&A box to drop our questions, comments, concerns regarding this presentation. So sieve out the questions and direct it to the presenter so that they will address all questions. So going by the agenda, the next is presentation by Dr. Winifred Kwonu. She will be taking us through improving treatment center readiness and utilizing it as a useful tool in the response architecture. Dr. Winifred, you have the floor.
Okay. Thank you very much, Dr. Bala. I hope I'm audible.
Yes, you are. Go ahead.
Thank you very much. Good morning. Welcome to everyone who is on this call. I will stand on existing protocol and thank you for the opportunity to be part of this webinar as a speaker. So we'll be going through treatment center readiness. However, what is being projected is preparedness, and I will speak a bit to that because some of the material that we're using is part of what was used for the pilot cohort of the Lassa Fever Clinical Management Fellowship that was implemented last year. It's a combined work for 7 foundational institutions, which is what I'll be presenting here. Next slide. So this is the outline that we will be using for this presentation. Next slide, please. Next slide. It's not moving on my end. Okay, I think I will just go on.
It's moving now. It's moving.
All right. Okay. Thank you very much. Okay. By way of the slides are down. Can we have them up, please? Thank you very much. So we all know Lassa fever is endemic. It's an infectious disease endemic in Nigeria. We have yearly outbreaks in Nigeria with surge of cases in the dry season, particularly around the months from December to March. And based on this piece of information about the seasonality of the disease, there is a need to always prepare and be in a state of readiness so that we lessen the impact of the disease and improve the outcome. And that helps in building the capacity and resiliency of our treatment centers. Next slide, please. So just a bit of overview as to the capabilities around public health preparedness and healthcare preparedness. And we see that there are some commonalities, between these two aspects. We have preparedness from a community perspective and the healthcare system, recovery from both aspects, and also emergency operations coordination, which cuts across. And that tells you that the treatment center is a part of the response architecture. It's a tool for response, to outbreaks generally. Of course, fertility management, information sharing, medical surge, responder safety and health, and of course, volunteer management. These are some capabilities that cut across these two aspects. Next slide, please. So there is, the term preparedness and readiness are used interchangeably. Some say, oh, we are prepared. Oh, some people say, oh, we're ready. But in actual fact, there is a slight difference between these two terms. And I will try to elaborate a bit on that. So for preparedness, it's a range of very deliberate and critical tasks and activities which are necessary because you want to improve on the operational capability to prevent, protect against, respond to, and recover from domestic incidents. It is a continuous process, so it's not a one-stop thing, or it's not just a one-off thing. And it involves efforts from all levels of governments, private sector, non-governmental organizations, to identify threats, determine vulnerabilities, and of course, the required resources, which is beyond finances and will include materials and human resource. But readiness speaks to the condition of being prepared. So it's a state that puts you in that situation to be able to act and respond in a timely manner. So you can do all the preparedness activities, but when it is time to act, we may not be able to act. And that is where readiness is essential. And that is what readiness speaks to. Next slide, please. So we'll be looking at the importance of being prepared and ready, and we'll be looking at it across three areas. Firstly, for the healthcare system, what does it support, or why is it important? It facilitates multi-sectoral and transdisciplinary approach. So we are looking at every stakeholder, it's facilitating that combined approach, to an outbreak. It provides a platform for early detection and institution of interventions. It helps to improve outcomes by reducing the case fatality rate. It supports research capacities because you are prepared. You are in that state of readiness to be able to build that capacity. It helps to improve community trust. Remember, I said there is that multi-sectoral approach, and it involves the community that the treatment center serves. So it helps to build that trust and confidence in the healthcare system. It ensures or encourages resource efficiency, helps to improve the system. It guides strategies for system resilience. And of course, it helps to create a pool of skilled manpower that can be easily mobilized or deployed when the need arises. Next slide, please. For the treatment center, being in a state of preparedness gives you the ability to be able to conduct an analysis, for example, a SWOT analysis, and help you to identify the gaps and your strengths, and you can optimize your strengths and opportunities and work on your gaps. Identify stakeholders that can be leveraged at any point in time. What are these stakeholders bringing? What strengths do they have that can be leveraged? It encourages ownership of the local adaptation of the response intervention. So a treatment center is able to come up with its own way that works within their system of addressing some of the issues, and they own it and they run it, and it becomes part of their system. It also helps to build research capacity, lessens the rates of nosocomial infections. It encourages resource efficiency, because you're dealing with a wide range of stakeholders and everything that you bring into the table. It strengthens the standardization of care because you have thought around, you're in that state of being ready to able to provide the care as much and as best as possible because you're using the guidelines to be able to do that. Reduction of case fatality rate and upholding ethical standards for the institution so that you do not have the risk of litigation happening when there is an outbreak. Next slide, please. And lastly, for the patients, what does it help them? How does it help the patients? Reducing morbidity and mortality, it boosts their confidence and helps to reduce costs, especially when there's out-of-pocket expenses, and of course, encourages community support for the patients. Next slide, please. So we'll be looking at the capacity developments and across 10 key areas. First is carrying out that readiness check, conducting the SWOT. You're identifying your assets, you're identifying your liabilities, you're building on your assets, you're trying to reduce your liabilities, you are in a state of addressing the risk that may be involved, of thinking about strategies to address perceived risk that may happen when you're in an outbreak. And through this, you're able to build an action plan for improvement. This must always be done before an outbreak starts. It is not when an outbreak starts, you now start doing a SWOT analysis. At that time, you're being a step ahead. You know, these days we talk about being one step ahead of the virus. You know, well, how can we be one step ahead? From a treatment center perspective, this shows how we can be a step ahead. And of course, it's not doing the SWOT analysis, having the action plan, and then just keeping that document in somebody's laptop, or you have the hard copy in a drawer. It should be presented to leadership for buy-in and implementation. Next slide, please. So looking at trainings, capacity building, we can't run away from it, but it has to be continuously done because people need to be in that state. Their minds need to be conditioned. They need to be ready. They need to have the right attitude. And every treatment center can work around having a plan for training. You know, that can be run manually and it can be run by cadres. And you have different models. You can have handbooks, you can have videos, clinical sessions, leveraging ground rounds, morbidity and mortality audits, sessions, you know, and what have you, those little or those opportunities where people come together to be able to talk or to be able to discuss. Those are avenues where capacities can be built. But repetition reinforces learning. So we do not say that you would teach somebody or you would train somebody and it will stick. People have different ways in which they absorb knowledge or they assimilate knowledge. So it has to be in a continuum. And of course, we cannot continue to impart knowledge, skill, without evaluating. We need to know if we're doing the right thing. We need to know if we're sharing the right information. We need to know if how we're sharing it is being assimilated properly. And of course, trainings can be built into orientations for new staff or the surge staff, or when you're doing refresher trainings for old staff, or it could be part of CMEs. These are ways in which you continuously tune people's minds, tune people's directions, tune people's thinking to be in that state of readiness to be able to respond to an outbreak. Next slide, please. So pre-positioning. So based on the readiness checklist, it's important that we're able to identify the materials that we need and ensure that they are stockpiled and that they are in the right quantity and quality and within the functional period. It is not when we're in the middle of the start of the Lassa fever outbreak or in the middle of the Lassa fever outbreak, we see that the ribavirin.
Sorry, Dr. Winifred.
Yes.
I wanted to cut you off since, but please, can you go closer to your mic? Can you speak up a bit more? I'm having some feedbacks here. Thank you.
All right. Thank you very much. Thank you. I hope it is better now.
Yes, it sounds better. Just speak up more. Thank you.
Okay. Thank you very much. Okay, so it's not in the middle of an outbreak that you're seeing that the ribavirin expired a month ago. It's not in the middle of an outbreak that you see that the PPE you have, once you just try to don it and wear it, it splits into two and it's not used, and it's not, you can't use it. That is not the time to start assessing those things. Those things have to be assessed prior to that time, because that keeps you in a state that you are ready to be able to address this. And of course, there needs to be a quality assurance mechanism that is put in place so that these commodities, we know that they are of the right quality and that they can be used. Remember, healthcare workers are the ones using these materials, most of these materials, to be able to respond to the outbreak through treatment of cases. A healthcare worker wants to be protected and wants to feel protected and wants to know that what he or she is using to protect him or herself is of the right quality and it will provide that protection. Next slide, please. Documentation. So having all the guidelines, all the job aids, the protocols to guide treatment of cases should be readily available. It's not at the start of the outbreak we say we don't have guidelines or we are disseminating guidelines or we're disseminating job aids, or people now really look at the job aids and know, oh, this is what this job aid is actually talking about. No, it is before the outbreak, because you need time for people to understand what these documents are talking about and be able to, able to imbibe it and understand it and interpret it within their context. So these things are basically front-loaded before an outbreak to keep people in that state of readiness, and they know that when I have a case, I do 1, 2, 3, these are the steps I'm supposed to take to be able to respond to that outbreak. And of course, any forms that will be required for documentation. It is not in the middle of the outbreak, you now find out that, okay, the forms, they are in the chief nursing officer's drawer in her office, and she's gone on leave, or she's gone for a training outside of the state. That is not the time to be having those conversations. These are forms that are needed. You know that you're going to have the data, the outbreak, you're going to manage cases, then they should be out in the places where they are needed. And in centers where you have an electronic medical record system, to ensure that this is functioning, it's not just there. That is your method in your facility to be able to capture data. That should be functional, and you should have a backup documentation system. Next slide, please. Human resource. So this is very critical, because the people at the treatment center are the ones who are going to respond to the outbreak through the care that is provided to infected patients. So there needs to be a team identified and adequately engaged. We don't get to an outbreak and we now start thinking, oh, okay, this patient, the renal parameters are dropping. I think we need a nephrologist to come and look at this person. No, you should have engaged. That nephrologist should have gone through some training. That nephrologist should have been properly engaged to be able to work there. And I know that colleagues that have worked in treatment centers in Nigeria, it's able to resonate with them, because it takes a while for you to get a colleague to say, based on your specialty, we need you to come and look at this person, but this person is in the Lassa Fever Treatment Center. And the person tells you, I will think about it, or the person shuns you, because the person doesn't know how he or she is going to deal with managing that person in that state in a Lassa Fever Treatment Center. So that engagement needs to have happened way before the outbreak. One beautiful thing that I always say, I will call it beautiful, it's Lassa fever, it shouldn't be beautiful, is that we have the data for Lassa fever for years. If we don't have from 1969 to now, in terms of good data, at least we can boast of data for the last 8 years. And that data speaks to a trend that has been on for the last 8 years. That data should be useful to us, should help with our planning, should help with our preparedness, and keeping us in that state of readiness. When we have an outbreak, we know that, with the death of, or the reduction of healthcare workers through Japa syndrome and what have you, there needs to be some level of rostering. You can't have 2 people in a physical location at the same time. So if you're going to be pulling from the main hospital human resource, there need to be some kind of roster being developed, for the treatment center, and of course for the entire hospital. Remember that the treatment center, and most of our treatment centers are located within a parent hospital, which is usually a teaching hospital. What happens in the teaching hospital? Business to continue. They should be seeing clients, they should be seeing patients. The treatment center, they're managing cases. So how does the treatment center function in states of an outbreak? And of course, the parent hospital continue to function to see other people who are coming there to access care. So that is why the rosters are important, to be able to align things and everybody knows where they should be at a certain period of time. And also in setting up systems to be able to reassign staff, engage staff through having a surge plan. Again, I say the data is there, and it is there at the treatment center level. You make those projections. We saw 100 cases. By the end of January, we had 100 cases, for instance. And with the number of healthcare workers we have, we do not think that we will be able to manage. We need to call for, backup, or we need to call for additional hands to come and support. It is not in the middle of an outbreak you're already doing that. You're saying, okay, I need to go a surge plan, and we're running helter-skelter. That has to be planned. People have to be in a state of preparedness. People have to be in a state of readiness. They are tuned to the fact that we're going to have extra hands. How are we going to accommodate these extra hands? What would they be doing? What will be their focus in the grand scheme of things when the outbreak happens? And of course, there needs to be a monitoring of occupational health and safety needs of the treatment center staff. People are rerouted from their main duties. They are asked to come and probably work additional hours. What is the hospital, what is the treatment center doing in terms of their welfare? These are things we need to consider. These are things we need to be talking about. First and foremost, remember, healthcare workers are human beings, baseline. Before you now start talking about what specialty you are, what profession you are, what kind of healthcare worker you are, if you're going to be doing some additional bits or going to be contributing to an outbreak response, then there should be those provisions for welfare. I mean, it's providing dinner for those who are doing overnight shifts and other contingencies. Okay, if a healthcare worker gets infected, what are the 1, 2, 3 steps that needs to be taken to ensure that this person is adequately taken care of, is moved out of the system, is taken care of, is able to get well, come back into the system. Those are things that we really need to think about, to be very, very intentional about, prior to an outbreak. Because again, like I said, the data has shown us when this will happen. Lassa fever is not a surprise. It doesn't spring up. It comes when the outbreak happens, when it should happen. From the data that we have, how are we using that data to inform the actions that we take to be able to fight the virus on an annual basis? Next slide, please. Next slide, please. I was on number 6. I was supposed to be on number 6. Thank you very much. So logistics. There needs to be a system for emergency purchase of commodities. Yes, you should have preposition. You should have checked quality assurance and all that. But then again, sometimes we have upsurge of cases that are not normal. What are those mechanisms in place to ensure that we're able to get commodities as soon as possible to be able to complement the ones we have when we are in that scenario? And of course, we need to identify and prepare the storage facilities to be able to accommodate and warehouse, stockpile all these commodities. Institute a proper inventory system to monitor and track. Identify, engage a dedicated storekeeper, somebody who has been trained, who understands what is important when there is an outbreak, and not when you need supplies and here the person has traveled to the next town and he traveled with the key. Those are not what we should be hearing during an outbreak, because everybody's work, no matter how little it is, contributes to the response efforts that goes on in a treatment center. There should be backup water and power And of course, a dedicated and functional ambulance. For the longest time that I can remember, there has been that push around having a dedicated ambulance. Some treatment centers have taken that up and dedicated an ambulance for Lassa fever patients, transfer patients, maybe from peripheral health facilities to the treatment center, or from a state to another state where there's a treatment center to be managed. But but that is good. But if we're thinking about that, it's not just to have the ambulance. Ambulance wouldn't move on its own. There needs to be a person operating that vehicle. That vehicle needs to be maintained. That vehicle needs to be fueled. It needs to be oiled. It needs to be bought. How have we factored that in? And put ourselves in that state of readiness that if we need to move a patient, we're not spending 24 hours, 48 hours trying to move somebody from point A to point B because the ambulance driver is not there, or they're trying to get money to buy fuel and things like that. Next slide, please. So in terms of information sharing, the treatment centers should be able to develop a communication plan and have this disseminated, because it's this plan that will guide how information goes out. Sometimes we have colleagues from the media who just go straight up to the treatment center and say, oh, we got information through the grapevine that you have, that 2 people died from Lassa fever. And depending on who they're talking to, you say, oh, yeah, so this is what happened. That's not what we want. We want to be able to manage and share information and share appropriate information. Cast our minds back to a couple of weeks, the situation in Shaki, in Oyo State, where, quack doctor died, the quack nurse died, and all that. We keep hearing that. But it shouldn't come to us as a surprise, because we know that that is a place, that is a local government that borders another country, and they usually have cases there. But the most important thing is, how is the information managed? How are we sharing the information to everybody, to our stakeholders? And this plan should be well communicated, so that if somebody is approached for information, he or she knows who to direct the interviewer to be able to get the right piece of information. Remember what happened with COVID? There was a lot of misinformation. And in the absence of information, misinformation happens. Anything goes, basically, and people will run with anything and put it out there and work with it. Next slide, please. So for security is very important, and I'm sure people wonder, why security? Yes, and I know that colleagues in treatment centers can relate to this, especially when you have upsurge of cases during an outbreak. You need security personnel to maintain law and order. There is that narrative out there, Lassa fever is an infectious disease. Yes, that's true. Sometimes you hear Lassa fever has no cure. Of course, we know that that's not true. Once you enter the Lassa fever treatment center, it is your body that is going to come out. You're not going to walk out alive. And you hear those kind of things, and patient relatives get agitated, they get worried, and they want to come to the treatment center. And remember that the treatment center is a secluded place, because not everybody should have access. So you need security to be able to provide some level of access control, within the space of the treatment center. And there should be a mechanism to ensure that there's adherence to whatever guidelines have been put in place by the treatment center to ensure security, that the security personnel you have are going with this guideline and not saying, okay, this person is my neighbor, let me allow him to go in, and go and peep and do all whatnot. They should be able to adhere to that guideline, and those checks need to be there. But this needs to be factored in, or this needs to be thought through, and whatever needs to be done before an outbreak starts should be put in place, and people are ready and in that state of readiness. Next slide, please. So for community engagement, it's important that the treatment center engages with the community that they serve. And this can be through awareness campaigns, dialogues, working with civil societies, grassroots organizations, traditional rulers, market leaders, and what have you, to be able to make that awareness, because you're opening the channels of communication so that when they hear something in the community, they know that they have a trusted source to be able to either to verify, that information. And of course, when those channels of communication are open, whatever advisories you're giving to the community, there is that high level of acceptance and commitment to complying with what the advisories say, because you have built trust in the health system. Next slide, please. Surveillance. So every treatment center should maintain a surveillance system. And what do I mean by this? There should be persons, designated persons, focal points at the different points of entry in the facility. The last speaker talked about various ways in which Lassa fever can present. So someone can come in with acute abdomen, rushed to surgical emergency, Lassa. Pediatric emergency, O&G, the antenatal clinic, the OPD, the A&E unit. These are different points of entry. We should have surveillance persons who are there to be able to support the team, so that when there is that suspicion that somebody who has walked in may be a likely Lassa fever case, then that person, the next steps on how that person can be isolated, put in the holding room, and the first few steps taken as to how that person should be addressed. Remember that the treatment center, you're in the middle of an outbreak, the treatment center is managing cases, but the bigger hospital is still working as normal. But there has to be that surveillance aspect to it, to ensure that in as much as you're managing cases, you're also still looking out for cases, especially for people who walk into the hospital for one form of care or service or the other. Next slide, please. So I'll summarize by saying that, or conclude by saying that, we need to address these concerns around preparedness to build the healthcare system resilience for outbreaks. And we've talked about the benefits of why we need to do this. And it helps us, especially in a time where resources are getting leaner and thinner, to be able to make judicious use of it. And being prepared, I beg your pardon, with the right attitude keeps us in a state of readiness. And with that, I come to the end of my presentation. Thank you very much.
Thank you very much, Dr. Winifred, for this elaborate presentation. So going by agenda, the next presentation, which is going to be the last presentation for the day, will be taken by Dr. John Tunde Aremu. He will take us through case study. Dr. Aremu, you have the floor.
Yeah, good morning, everyone. Please confirm if you can hear me.
Yes, loud and clear. You can go ahead.
Good morning, good afternoon, wherever you are across the world. First, let me appreciate the organizers of this webinar and for inviting me to take part in this discussion. So I'll be looking at a part of preparedness management that is majorly neglected in our response to either Lassa fever or other epidemic-prone diseases. So I'll be talking on the cascade of clinical care and linkages to the EOC, Emergency Operations Center, as the coordinating mechanism for outbreak response. Next slide, please. So I'll be going through this guideline. I'll be looking at the scenario, which is a true life story from Gombe. Then I'll look briefly at the Lassa virus disease, and I'll give my final thoughts at the end of the presentation. Next slide, please. Next slide. So the case is about a 40-year-old man. He is an earthman. He presented to the outpatient department of General Hospital Kaltungo, which is a local government in the Gombe Southern Senatorial District. with a 6-day history of fever, malaise, and sore throat. He had an episode of epistaxis 5 days prior to presentation. He was given anti-malaria at a patent medicine store with no improvement in symptoms. The patient, on arrival at the GOPD, GH Katungo, the medical officer saw him and he felt that he met the case definition of Lassa fever. After taking the history and examination, the patient was isolated in an holding area, and the medical officer informed the local government DSNO, Disease Surveillance and Notification Officer. The LGA DSNO informed the state epidemiologists at the State's Emergency Operations Center. We in turn informed the case management pillar lead, the IPC pillar lead, and the lab focal person. The EOC decided that a line list should be generated and the samples should be collected for the diagnosis of Lassa virus disease. A spot trip was generated by the state's epidemiologists and sent to the incident manager. By the way, most of the officers here are actually located at EOC. So the case manager reviewed the case and confirmed that the case definition was met. He informed the logistics pillar lead who sent drugs, IPC materials, and other consumables to GH Kaltungo. 5 people were initially line listed from the household of the index case, including the wife, who had similar symptoms, but in addition, she had hematemesis. Samples were taken from 3 of the line listed suspected cases. The samples were sent to the Bauchi reference lab. The case management lead informed the medical officer to commence ribavirin. The incident manager summoned the EOC for an emergency meeting. Next slide, please. Then it was agreed that the patient and the wife should continue management at the treatment center at Kaltungo, pending the results. And the surveillance team should be deployed to Kaltungo for further assessments and more line listing of suspected cases. The case manager also requested to be in Kaltungo to reassess the patient. An ambulance was kept on standby if an immediate transfer to the isolation center in Gombe would be needed. And the GH Kaltungo Treatment Center WhatsApp group informed the EOC daily of patients' condition. The patients were adequately counseled about the options available in case of deterioration of their symptoms. The medical officer was reminded of the treatment protocols and the IPC measures to be taken. Next slide, please. So the patients were monitored daily. By this time, 2 patients were on admission. They were monitored daily while still on ribavirin treatment. Results were received after 72 hours. The state's epidemiologist generated a CTREP and sent it to the incident manager and the NCDC in Abuja. Patients were improving and there were no evidence of any active bleeding. Liver enzymes were slightly raised, but renal functions were essentially normal. The EOC deliberated on whether to move the patient to the isolation area at the state capital or be left at the Kaltungo Treatment Center. Opinions were divided, but the case manager advised that we continue treatment at Kaltungo based on the fact that the patients were improving with no danger signs, and the patients preferred to stay at Kaltungo, which is closer home. The other members agreed, and the incident manager directed that the EOC support the GH Kaltungo team with every resource that they need. Next slide, please. So the 2 patients completed a treatment at the isolation center at GH Kaltungo and were discharged. There were no other cases detected at that time. The EOC decided that sensitization training should immediately be conducted at Kaltungo General Hospital, The IPC lead should also supervise the fumigation exercise. IC's materials were also sent to GH Kaltungo and to the facility, and the risk communication pillar lead was also advised to lead the sensitization activities in the local government area. Next slide. Next slide, please. Okay, so based on the story, the case scenario that just relayed to us, we can see that there are some decisions in this patient's management that can only be taken at a higher level. For example, we do not have a dedicated ambulance, but the incident manager, who is the commissioner of health, had the power to say, okay, dedicate one ambulance in case we need to evacuate the patient. These are some of the benefits that coordination from the EOC will give to treatment centers, where some of these initiatives cannot be taken by this treatment center, or there is no political backing to do some of these things. Briefly, this is what Dr. Joseph already spoken about. Let's remind ourselves that Lassa fever is still endemic. Clinical features can be challenging to differentiate from other febrile illness. But for the particular patients, the high index of suspicion played a role. The medical officer, what actually came out to him was that the patient is still febrile despite taking anti-malaria and had episode of epistaxis. So everybody belongs to surveillance team, from the hospital to the community, and including the surveillance pillar lead. And let's also remember that some of them may actually present asymptomatic. So IPC, as we go into the months where the surge is expected, let's remember that IPC will be very key in our preventive efforts. Next slide. So I think all of this has been discussed by Dr. Joseph and some of them by Dr. Isaac. So let's move to the next slide. So what is the Emergency Operations Center? Just like I said, this is probably one of the missing link in our response to outbreaks, especially Lassa fever and other emergency prone diseases. It is a weak link because there are some states that probably have 3 different isolation centers, and all of them work in silos. There are no general coordination units. So what is the EOC? It's an emergency operations center. It's a physical location, just like every building you have in any government establishment, for the coordination of information and resources to support the incident management activities for any incidents. In this case, we are referring to the Lassa fever. So it means that regardless of where the patient is being treated, there must be an overriding coordination system that will be overseeing all of this, because it's a physical location. And the personnel in that EOC are responsible for planning, coordinating, organizing, acquiring and allocating resources. So most of the aspect of Dr. Winifred's discussion, the readiness, most of those activities will take place at the EOC before the outbreak actually commences. Next slide, please. Then the PHEOC is the Emergency Operations Center, which is specializing in command, control, and coordination requirements, responding to emergencies involving health consequences and public health. And we all know that PHEOC works in 3 modes. We have the watch mode, which every EOC is on the watch mode. What is different here is that for many isolation centers, they do not recognize this watch mode. So the EOC does the watch mode, it gathers the information, he has his informants everywhere in the community, and there is the alert mode, there is respond mode. And the way the EOC will respond is actually classified into 3 aspects. Next slide. So the first mode of responding is the public health impact is limited to 1 local government. For the case I presented, that patient was found in Kaltungo local government. So regardless of whether the case is in 1 local government or the case has gone beyond the local government and affected other local governments in the state, or the case have got an international impact, an international dimension, regardless of which one of the cases, the EOC has a central role in coordinating. What is different between whether it is first, second, and third? It depends on the type of coordination, the types of collaboration, and the types of interagency collaboration that you need, and the type of assistance that you need for response. So if you do not really classify the incident you have at hand, you may be missing the type of collaborations you need. And it is the only EOC that can do this kind of collaboration. Each facility may not be able to collaborate with the national or international agencies to respond to every event. So that's where the EOC becomes a very, very important tool in responding to events or outbreaks. Next slide, please. So the basic working ingredient in the EOC is the incident management system. And you need some information to activate it. It is called the critical information requirement. There are a comprehensive list of information which is provided to the EOC. These requirements affect the successful accomplishment of the EOC objective of controlling the current outbreak. Next slide. So for the case of Lassa fever, these informations are important. For example, any laboratory confirmed case of Lassa fever, a facility may just decide to work with the lab and send a sample to be confirmed. But if this information does not get to the EOC or get to the state epidemiologist, then there may be a problem. Death of a suspected case of Lassa fever. So putting all of this critical information together will now make the EOC to take the next step. Next slide, please. So the incident management system will be activated based on the information that have been gathered in the street. The incident management system provides a standardized approach to response management. It is modular, it is scalable, and it's adaptable. It has a standardized, flexible component as the organizational structure expands or reduces in size to address changing requirements. The structure adapts to changes in demand without the need to reconfigure a base structure. So if you look at the incident management system is central. It has all the components of management. There is the prevention, protection, mitigation, response, and recovery. So this incident management system does the daily running of control of the outbreak. Next slide, please. So this is an organogram that shows all the actors in the incident management system. First of all, once all of those informations have been gathered, then the EOC will agree that there should be an activation of the incident management system, and an incident manager will be appointed. Most times in Gombe State is usually the Commissioner of Health. In his absence, the Director of Public Health takes control. And if you look at this organogram, every pillar is represented here, from logistics to planning to risk communication to laboratory case management, epi, and surveillance. And under each of these pillars, there are also other activities that take place in them. So in the meeting of the incident management system, taking into the consideration the patient I just presented, the case manager or the case management pillar lead will present the case. The laboratory pillar lead will tell us what has been done to these patients. Then the logistic will tell us that, okay, we don't have ribavirin and we have moved some of this ribavirin. And at the end of this meeting, the information generated from this sitting is made available to everybody. Once upon a time in the States, the information that gets out is actually different. In short, there was a time that somebody was on radio, gave an information, the commissioner was not aware of it, the governor summoned the commissioner, and at the end of the day, you have three different stories. So with the incident management system, the flow is the same, the information coming out of the state is the same. At every point in time, anybody in the incident management system, heading any pillar, will know the number of cases, will know the number of fatalities, and we also know the number of discharges. The information going out is completely dependent on the incident manager. He can decide to hold a press conference, or he can decide to delegate somebody to do it. But all in all, the state epidemiologists or the people in charge of the surveillance unit must update the incident manager every day on the goings. And if there's any new thing that we really need to sit and discuss, for example, in this case, we had the problem of whether to keep the patient in GH Kaltungo or bring him to Gombe. But when we sat down in the incident management system, everybody agreed that with the available evidence for us, let's continue the management in the GH Kaltungo. The patient did well, was discharged, and the less resources was used, but a better coordination activity was deployed. So that is the importance of the EOC, which is lacking in many states. Regardless of how many isolation centers you have, you really need that overarching coordinating system that makes sure that everything in the states is known to the key players and everybody takes responsibility for what they are supposed to do. Next slide. So what are my final thoughts? Lassa fever is still endemic in Nigeria. Diagnosis may be difficult because of the various differential diagnoses. We all agree that high index of suspicion is needed. Case fatalities are increasing, and we can reverse this by more coordination in our activities in the states. A structure such as the EOC is needed to coordinate response, collaborations, resource mobilizations, government involvement, interagency collaborations, right, spread of logistics and drug supply. The EOC in Gombe has improved our response to Lassa fever outbreak and other epidemic-prone diseases. It had also increased government involvement in response activities. And this is much more important because sometimes when some logistics are not available, it is easier for the commissioner to ask the governor to do certain things than from a facility to ask the government to do the same thing. The outcome of case management of any Lassa fever disease will be significantly improved by better coordination from the EOC. Next slide. So this one of the initiatives of Dr. Wilfred, NCDC, and his group, the LCM Fellowship. We thank them for the opportunity to be part of this. Next slide. Next slide. So I want to appreciate everybody for listening and also appreciate NCDC for the opportunity to take part in this webinar series. Thank you very much, and over.
Thank you very much, Dr. Aremu. So next on the agenda, it's going to be the post. We are going to have the post test. Yes. Kindly look at the screen. It's been projected. So because of time, each question will just take 30 seconds. Let's try and respond on time so that we'll move on.
Colleagues from eHealth, please, the poll. Thank you.
Yes, thank you. Each question, 30 seconds, please.
Please, once we have 50% response, we can move on.
Really hear anything. Dr. Yetunde? I don't know why I can't hear.
Yeah, but we can hear you.
Please, can we have the next? Thank you.
Dr. Yetunde, are we done, please?
Not yet. I think we have the last question up. Once we have 50%, please kindly turn it. Thank you. Okay, so this is the last one. Okay, how many percent more do we have left?
Just about 2%.
Okay, colleagues, please kindly take part in the last poll. Afterwards, we would review the right answers, as this is a learning curve for every one of us. And then afterwards, we'll go into the Q&A proper from the panelists. Remember, only questions in the Q&A box will be answered. All right, thank you so much. So are we having the answers being projected now?
Yes, so
Okay, so I'm just seeing a poll. I'm not seeing the answers.
it's at the bottom.
Okay, can anybody, colleagues, my fellow panelists, can you confirm if you can see this?
Where exactly at the bottom? I can't see any of.
Okay, I can see now.
Okay.
Yes, I can see now. Thank you so much. Okay, so let's have the next one, please. Okay, so I believe most people can see that. And then the last one. Very, very important. Very important. All right. Probably a few seconds more. Thank you so much. We really appreciate your support. So over to you, Dr. Bala, for the Q&A session.
All right, thank you, everyone. So we are moving into the question and answer session now. Looking at the Q&A chat, we've received a quite number of questions, and most of the questions are directed to Dr. Joseph, even though some of the questions were answered on the chat box by Dr. Winifred. So Dr. Joseph, should I read out the questions for you, or you can do that from your end?
Yeah, please do. Just help me identify the one I should answer. Can you hear
me? Okay. Yes, I can hear you. I can hear you.
All right.
But please speak up. You seem far from your mic.
Yes, Dr. Jacob.
That's exactly the problem I'm having with my device.
It's the network, most likely.
But I will just try and talk like this. I'm actually with the device. Probably it's a network problem from my end.
So let me start with this very first one. I think it's from Professor Tomori. Great series.
Okay.
Creating awareness among healthcare workers. So what plans to do the same, creating awareness, educate, prepare, and involve at the community level where most Lassa fever cases originate. And he also made mention about stabilizing the patients first. When we suspected Lassa fever, and also mentioned the use of ribavirin. So when should the use of ribavirin be started, at what dose, and for what duration?
Okay, thank you very much. I'm actually very happy that we are having seasoned colleagues on this platform. Professor Tomori is one of the pioneers in our institution. We have his picture in our wall of fame in our institution. So he has also contributed quite much to where we are today at the institute. But going forward, I think, having to sustain a program like this, we really have to be a joint approach, because we know that it's a good initiative. And I'm happy that the NCDC has come up with this. And of course, I know the Nigeria Center for Disease Control is also working with the Federal Ministry of Health to continue to push this. I remember an event that happened with the Georgetown University in 2023 that we're able to also organize a Lassa fever fellowship. Apart from just dwelling on case management and a couple of other things, we were able to also reach out to a couple of people on what we should be doing, particularly when we approach outbreaks like this. Yes, I believe apart from this, there should be an effort to build some capacities within the communities. We should have policy makers getting interested to continue to drive programs like this from the federal level. Yes, it's fine, but we should have more coming from the state level, the state government, the local government, and of course, we should begin to work on our communities, have a couple of community outreaches, and building more capacities within institutions and in the communities, and introducing sustainable measures. And this we cannot do without properly looking out for probably a dedicated fund to drive this, and having focal people at every region in Nigeria to actually drive this. So I'm happy that the NCDC is pushing it, and over time, we're going to get more people being interested in driving the program across all the geopolitical zones of the country. This is very key. And then talking about attending to a suspected case of a Lassa virus patient. When we have all these together, patient coming in with these identified clinical signs and symptoms, and then with some lead assessment we have done, we are now suspecting that this patient could have Lassa virus disease. The next thing we should do is to, first of all, isolate this patient, keep the patient in a holding area, and then we send sample for a real-time reverse transcriptase Lassa virus disease polymerase chain reaction for testing. This is very important. And I understand that many facilities do not have this, So it's therefore very important that we have a high index of suspicion, and we're able to connect with facilities that can carry out some of these investigations. There are different scenarios. You can just have a regular suspect case with mild disease. Some will come with already very severe disease, what we call probable cases. Probable cases, you are seeing a patient who have very suspicious features of Lassa, or probably has had a contact with somebody who died from the disease, or a person that have all suspicious features and you're already having organ dysfunction. Such a patient qualifies for a probable case, and probably you may not be waiting to have result of investigation before you commence that kind of person on ribavirin, which is still the only known medication that is definitive for treatment. The ribavirin in itself is toxic, and it's not a drug you just want to start quickly for many patients, particularly a patient who is having renal compromise. You may want to cut down the dose that probably want to give to such patients. So you may want to now discuss with people who have actually managed some of these cases. That discussion is very key. And when you suspect a patient, you have a very high index, you are sure that this person could have Lassa fever. Apart from discussing on how to get the samples tested, get the samples to facilities where they can be tested, it's also important that if you have not managed such a patient before, you discuss with those who have been managed. We now have Lassa centers in almost all the regions in Nigeria. We have in South ISTH, you have in the Southeast, Abakaliki is there. In the Southwest, you have FMC or War. In the North, you have a couple of places. Bauchi is growing very, very, very fast. Abuja is central, where we have the National Reference Laboratory. So a couple of places you can get, a couple of people you can call. Unfortunately, we don't have rapid diagnostic test kit, which can be very handy at this time. And I believe it's something that we should begin to push. We should begin to work on important research to develop rapid diagnostic test kits that can be used in many centers, not just for screening, but for confirmatory purposes in many centers, because they will become very handy in many communities that are very far from reaching diagnostic institutions. These are some of the things I want to talk about. But yes, supportive investigation is very key. It's very, very key to a patient that have been suspected to have Lassa virus disease or have been confirmed to have the Lassa fever, that have been confirmed to have Lassa fever. Thank you.
All right, sir, thank you for this response. So still again to you, sir, I have another question here that you made mention of breast engorgement and intrauterine fetal death as prognostic features, signs, symptoms among pregnant women. So what other symptoms and signs that could be of prognostic value among children and adults?
Thank you. Like I said, pregnant women and children are special population. They are vulnerable population, and their chances of dying from the disease are very high, very high. Many pregnant patients presenting with mild disease, we often present with a viable pregnancy. When a woman comes to you with a viable pregnancy and Lassa virus disease, the chances of dying is quite low. It's also suggestive that, yes, you could do something to save that woman. At the point that the patient is coming in with a dead fetus, it goes to show that you may now have a very high load of viruses within the placenta, and the risk of an IUFD for an obstetrician, including the risk of DIC, coupled with what the Lassa virus disease could also cause, we multiply the complication that patient probably have. So the chances of dying is very high. So we often say that, yes, intrauterine fetal death is a poor prognostic factor. Carrying a viable pregnancy is a good prognostic factor, as well as other features which we have seen, such as disseminated intravascular coagulopathy. When a patient comes in and is very bad, presenting with shock, encephalopathy, seizure. There are many times you come into labor ward during an emergency and you have a patient coming in and presenting with seizure, atypical presentation, which in many cases, many people will mimic as eclampsia. You think this patient is eclamptic, but the patient is just manifesting some cerebral manifestation of the Lassa virus disease. It can be very confusing, and we have seen this in many cases and from many patients and many points in time. You know, the other aspect we have seen with very poor prognostic factors are patients that come in bleeding, could come in second and third trimester with antepartum hemorrhages, and particularly to labor ward just after delivery. With postpartum bleed, the patient continues to bleed, and you think that you want to control hemorrhage. Patient is not, bleeding is not stopping. You probably want to take the patient to the theater for hysterectomy, and you can't control the bleeding in the theater. It's one of the commonest cause of death for many of these. So these are other poor prognostic features. We must also look out for, particularly during the period of outbreak, dry season like this, when you know that Lassa virus disease can be quite high, and for the fact that the patient may be an indigent patient coming from a rural environment, with poor environment, with high chance of being exposed to the mastomys rat, this should be highly suspected in such patients. And then for children, children come in with acute fever. Temperature can be very high, quite high, and of course you can give several forms of medication and the patient is still febrile, and in many cases the child may have had several treatment, over-the-counter treatment, and coming back to you in the hospital, and atypical pneumonia in some cases, and many signs of jaundice, hepatomegaly, and sometimes generalized body swelling in some children may just give you a lead that possibly this could actually be a Lassa fever. And in both cases, when you do a urinalysis and the person is having proteinuria, hematuria, as well as elevated liver enzymes, these are just, few other factors you will find, during your initial assessment. I'll tell you that this possibly could actually be Lassa virus disease. And of course, shock in children can be very severe. See, a child can be weak, have malaria, severe shock, hypoglycemia, a difficult to manage child, and it becomes now very difficult. Encephalopathy too. Some children, you could do a CSF, it has a positive CSF, and the serum blood is testing negative. We had a couple of atypical cases like this. So there are things you have to look out for. Overall, index of suspicion is very key and has to be very high, particularly at this period of Lassa fever outbreak. Thank you.
Thank you very much, sir, for this elaborate response. The questions are still plenty. So do you mind taking one more, responding to one more?
Ask more.
So, okay. I think this very question is, the person knows you. He said, remember a long time ago in Irua Specialist Hospital, suspected cases or diagnosis of Lassa fever used to instigate so much fear that nobody wants to come near patient. So he's asking what has changed in Irua now. Healthcare workers are no longer scared of the virus. What are the healthcare workers doing that they are not getting infected? And then he also asked, what advice do you have for other institutions just coming on board in the management of Lassa fever and the public at large?
Yeah, a couple of things. A couple of things have changed. And let me tell you again, let me just let you know that in the past 15 years, in the past 10 to 15 years, I'm not sure we've lost any, we have not lost any of our staff working at the institute, working from Lassa fever. They may have died from other illness, but not from Lassa. From Lassa, we have not, had any staff overtly infected and dying from the disease. Working in the institute, very rare to have a staff working at institute getting the Lassa fever because of a couple of things that have happened over time. The few staff that become infected at some point from Lassa fever in our institution are very sporadic. And when you look at it, it may not primarily be coming from the hospital. It just be coming from, environmental factor, from their exposures to the environment where they stay, and a couple of other things. Because to a very large extent, there have been efforts. There have been effort by the institution to put in some measures to develop and advance infection prevention and control, which NCDC pushed so strongly, so strongly, to the grassroots. Not just within the institute, but in other areas, because we don't only deal on Lassa virus disease alone. We also attend to other emerging pathogens. We have a couple of dengue confirmed cases, which we have gotten through research, yellow fever. In fact, we are living in the VHF, viral hemorrhagic fever belt. So we attend to a couple of pathogens. That's why the institute currently changed to rename as the Institute of Viral and Emergent Pathogen Control and Research, because we attend to dengue fever, yellow fever, Marburg, and even Ebola, But one will say that, yes, over time we have evolved. And I want to say that for centers all centers, even if you haven't started managing a high priority pathogens like this, it's important to always expect that you could have a case at a particular time. So you must identify what we call a holding area. You have to start from identifying a holding area within your institution. That holding area can be used for suspected high priority pathogens. When COVID came the other time, many institutions were confused on how to manage some of these cases. It shouldn't just be Lassa. There should be a room that is kept aside and say, okay, when this happens, these are already available. Continue to build your team. There are a couple of trainings that are available. The Georgetown University recently conducted a fellowship on case management for Lassa virus disease, and I know that we are expecting them to conduct another training very soon in the coming few months, and I believe that many centers may want to key to it. I know that there are specific courses being run by the Nigeria Center for Disease Control, and locally, I know there are some, programs that are being run by my institution and FMC Award. So many centers can easily identify nurses, some doctors, and even some lab scientists to take rotation through key laboratories where some of these trainings can be done. Molecular laboratory on PCR diagnostics. Once you're a laboratory scientist, it's easy to go through some of this training and have a good understanding. And many centers who are big, public and private institutions can set up PCR diagnostic facility for this kind of test. It's a bit expensive to set up one unit of PCR diagnosis, may take over 300 million, but this can be factored into some budget for some institutions and can easily be done. But most importantly, we must have a holding area. We will have dedicated nurses, institutional response team that can attend to suspected cases like this for Lassa fever, where to first of all keep them and have connections to centers where diagnosis can be made in the interim prior to when some of these things can be done. And if you even require some centers to come into your place in the event of an outbreak, there are mobile laboratory. We have an organized mobile laboratory, functional within our site. I know that NCDC also have a functional mobile laboratory that is very functional. I know that when such a call comes, people can always be deployed to such centers if there are so many cases of suspected cases to help with testing and all that during period of outbreaks like this. Thank you very much. Thank you.
Thank you for your response, sir. So few more questions again. So you spoke about stabilizing patients first when you suspect Lassa fever and also recommended the use of ribavirin. So this question is saying, when should the ribavirin be started and at what dose and for what duration?
Okay.
And then a rider question that also speaks around the use of ribavirin still. This one says, how early is the recommendation for initiation of ribavirin, and also does commencing it early have any positive outcome or prognosis? Thank you.
All right, thank you very much. Ribavirin still remains the only known drug, although it hasn't gone through any form of clinical trial to actually ascertain the effectiveness of this drug. But for many people who have used it, they say it works. There is still effort by the World Health Organization to introduce new drugs and therapeutics. That's one of the WHO R&D roadmap to develop new drug and therapeutic. And that's why there are currently several consortiums like the Integrate Consortium who have been saddled with the responsibility to develop new drugs. Some drugs may actually be better than ribavirin, but yes, what we currently have is still the ribavirin. And we know that with early initiation of ribavirin along with supportive therapy, that supportive is very key. IV fluid, you control shock, take patient out of shock, give blood if patient is anemic, treat for infection, patient is infective. These are important for case management, for the ribavirin to work. Ribavirin can actually be very toxic, can cause hemolysis and cause anemia, renal compromise, the patient who already have suppressed renal status. This should always be borne in mind when we think of ribavirin. But early use of ribavirin is key, and for moderate to severe cases, it's always advised that ribavirin is commenced very early. Now, For high suspect cases which have been kept in holding area, it's important that we get result of investigation before starting for a large number of patients. However, for probable cases, the ones you are sure that, yes, this patient needs to be commenced on ribavirin, patients should be started immediately on arrival without having to wait for the medication, without having to wait for the result of investigation, because it may take some time in our site. Once you send sample, within 12 hours the result of the sample is ready, but it's the difficulty logistics in getting sample across to such centers where the sample can be tested. That's actually the challenge in most cases. But I can tell you that ribavirin should be started immediately if we feel that it's a probable case or a very severe case that we need to start ribavirin for. But we should also expect that more drugs are on their way. A couple of drugs are being tried, and also the effectiveness for ribavirin will soon be put into test to be sure that to actually know the dose and formulation that should be made that will be effective for the management of for the care of Lassa fever confirmed patients. Thank you.
Thank you very much for these responses, sir. Dr. Winifred.
Yes, I'm here.
Yeah, so that very question that was directed to you, even though you've responded to most of the questions via the chat, via the Q&A chats.
Yes.
Okay.
Which question in particular?
I'm trying to get the question.
Okay. Is it the one about the mortuary?
Yes. Thank you.
Okay. Oh yeah, so there was a question around the mortuary being a part of I remember correctly what the question was talking about. It's in this, the consideration for mortuary, because that is usually not in the plan when the treatment center is being built. Yes, because firstly, most of the treatment centers that we have are how would I put it? They came about because that particular state was experiencing Lassa fever, and they have become and they were makeshift measures to ensure that you have places where you manage cases. However, I know that in the last couple of years, the NCDC has set up treatment centers in some states, and I think they're currently doing that in other states as well. And in that treatment center floor plan or outlay, there's usually that space for a treatment, for a mortuary, as part of that treatment center outlay. I usually describe a treatment center as a mini teaching hospital within a bigger teaching hospital, because you have every aspect of a teaching hospital. In that treatment center, you have beds, you have the wards, you have the pharmacy, you have the dialysis room, you have the delivery room, you have the ICU. That is what a treatment center should look like. However, what is being built in a way that it's able to accommodate, but there is an outlay, and that outlay has a mortuary component to it, so that if a case of somebody who is being managed for Lassa fever, if a person dies, there isn't that need for a long transportation to the treatment to the mortuary in the hospital. You're able to do institute all the IPC measures for debug the case and the corpse, and have the corpse there and ready for the burial team to be able to move to where the person will be buried. So yes, that is what the plan, the outlay, describes, or that you have that there. But what facilities have been able to do, more like a cost saving measure, is that in their main mortuary in the hospital, they've been able to dedicate a section to say that this is where we will keep corpses of people who die from Lassa fever. And The mortuary staff, the attendants, everybody who works in the mortuary is trained, trained on IPC, trained on how to body bag, trained on trained on what they need to know when somebody who has died from Lassa fever, the body is brought to the mortuary, so that they themselves, who are the staff working at the mortuary, are also protected from getting infected by, touching or trying to ensure that this person is taken care of, and you have everything that the person needs to, everything that needs to be done to the corpse, but to be done in a very safe manner. So that's a cost-saving measure for treatment centers that are already existing. For those that are cropping up, those that are new, yes, you can factor it in when building the treatment centers, when setting it up. That can be factored in that treatment center, so that you have the mortuary being something that is very close or within the premises where the treatment center is situated, just as a way of ensuring that everything is in one space, and it helps with how cases and dead bodies are managed. I hope I've been able to respond to that question. Thank you.
Yeah, thank you very much, Dr. Winifred. Dr. Aremu, any word of advice? Final word of advice?
All right, thank you very much. You can see that Dr. Joseph was getting billions of questions. Yeah, it's just to show that a lot of work has been done with training in case management, training in IPC, and also training in preparedness. But we still need to look at that gap between the isolation units and the EOCs. And for us to sustain our response, both at the local, the state, and the national level, we must start looking at the direction of the EOC as the main coordinating body. So for all my fellow case management pillar leads, I think you need to work more with the states and recognize that there is an EOC and they have a function. I'm fortunate that I was part of the training during the activation of the EOC in my state. So I think for us to sustain this fight, we need to have a very good coordination, and I think the EOC will be the best way to achieve this. Thank you very much, and it's over from me.
Thank you very much, Dr. Aremu. So at this point, I would like to appreciate all the speakers for making this wonderful presentation and responding to almost all the questions. Apologies, because of time, some of the questions could not be addressed. So at this moment, I would invite Dr. Yetunde to give us a conclusion and closing. Hello?
All right, thank you so much, Dr. Bala.
All right.
Thank you very much for that wonderful moderation of the Q&A sessions. So our dear colleagues and partners all over the world, we're really grateful to be able to have hosted this session. And despite the fact that we've exceeded even the time we planned to, we're happy to have over 230 people join the call and still be on the call at this time, actively engaging. I'm very sure that we have been able to encourage your index of suspicion, especially among our clinicians. You've also shared our wealth of knowledge in Lassa fever readiness in Nigeria. And we are hoping that will also improve early reporting of cases from communities. I remember the question Professor Oyewole Tamori asked, and this is a very key part for us, especially as part of our objectives. So we believe that communities have a role to play because we know these outbreaks occur in communities. And if we have cases presenting early, we'll also be able to treat them better. And we've also believed that collectively, we've been able to improve readiness for Lassa fever management and control across the country. And with this in mind, we hope that we'll have a better outbreak season, as we have an imminent outbreak on our hands. All efforts, all hands needs to be on deck. I also liked what Dr. Aremu said about the fact that clinicians should also very much work with the emergency operation centers located in their state to be able to also get support. We are the national, as a national TWG, when we activate our EOC nationally, we'll also be supporting states at the level of the EOC and also the treatment centers, but most likely, most of our support also comes through the states. So it's very, very important. We have dedicated treatment centers across the country, but then every health facility should be able to have a holding area where you can be able to treat cases. So what we'll also do at the end of this is also to share a link to a short course which our colleagues from Resolve to Save Lives in partnership with primary health care and some of our other partners were able to develop, just to also share this for clinicians to also take this course and realize the reporting channel and how all these things link together. We all have a role to play, and it's our collective responsibility to ensure that we reduce the case fatality rate of Lassa fever to a less than 10%, which is the national goal collectively. Thank you so much, colleagues. I think at this point it's safe to say, enjoy the rest of your day and have a wonderful weekend. Thank you so much. Look forward to hosting you again the next webinar, which is next week, Thursday. Thank you very much and bye for now.
Thank you, everyone. Have a great day.